Hello, Protrusive. I'm Jazz Galati, and welcome back to another group function, again oral surgery. We're doing a three-part for oral surgery with Chris Waith. We already covered dry sockets, and his answer was very surprising to me. This one, OACs, was a bit more what I expected to hear, and so we're going to jump straight in, right? You are now very familiar with these group functions. So how do you prevent and manage an OAC? Shall we move on to now OAC? They'll say AOCs. OACs. Okay, so OACs, I was taught at dental school that a lot of times when we take a tooth out, we probably make an OAC without even realizing, and it's a very common thing, and actually it probably heals up, especially when it's less than X millimeters, maybe that's 4 millimeters or whatever it might be. I was also taught, and here's why I've been a little bit naughty. So let's play Zach's in Zach's absence. Let's play Am I Naughty If? Am I naughty if I get my pay? If I'm really not sure if there's an OAC, and then I want to start them on the regimen, which we'll talk about shortly and see if our regimens are the same. But if I'm really not sure, then am I naughty if I get them to pinch their nose and try and blow out their nose, aka the Valsalva maneuver? Because I was taught not to, but a few times I'm really not sure whether I'm about to start this patient on the regimen. I have done it. What do you think?
I'd say yes, you are naughty.
Okay, I shall not do that
again. I mean, my logic is that I think we must cause OACs all the time, but 99% plus they just heal. Some of the time it will be because the membrane's completely intact and the communication is actually, it's just a bony break. Sometimes the hole in the membrane will be so small that your body can heal it. If you've got a small hole and you squeeze your nose and blow, essentially what we've just got them to do is what we're about to instruct them not to do for the next 2 weeks, because we know it might open up the OAC. So I would say if you're going to check, grab your suction off your nurse so that she's not tempted to put it down to the bottom of the socket. Just get your suction over the top of the socket, either get the light from your loops or your chair light in a decent position, and just look. And I think if you can't see anything obvious, it's not to say it's not there, but if you can't see it, that's good. Because like I usually teach 5 millimeters. I say less than 5 millimeters, I think you can kind of sit on that, give them the instructions, and I try and make myself feel better. I put some collagen cubes in the coronal portion of the socket.
Yeah,
and
so do I.
If it's bigger than 5 millimeters, you're into the point where I don't necessarily think we should be expecting GDPs to do something super courageous at that point. Like if you were thinking that actually needs some kind of physical closure, I think if you're the GDP, the quickest, simplest thing you could do is just take an alginate. Send it to the lab, just say to the lab, this needs to be kind of processed now. So we need a bit of a favour. And you want a clear blowdown. So clear blowdown to cover all of the teeth, but also...
Like an Essex retainer.
Yeah, Essex. Yeah, so an Essex that grips the socket. So it's got to be tight over the socket. And the logic is then, you put that in and you say to the patient, you wear this 100% of the time, with the exception of taking it out to brush your teeth. While they're eating and drinking, they haven't got food and drink going up into the sinus, so that you're trying to prevent them getting a sinusitis. Really, you can go 2 ways with it. One is if it definitely needs closing, that's great. Refer them, but they wear that until they see the surgeon. Or you might say, do I still try and treat this conservatively? So the last one I saw was last summer when one of our associates took a tooth out. About a week later, the clot broke down and they started to get some nasal regurgitation. I numbed him up and cleaned the socket out, but when I looked, the hole was so small that I just thought, if I'd taken this tooth out now, I wouldn't close this. So I thought, you know what, I'll put some collagen cubes in and I'll suture it like I would do, but I'll take that alginate. And I got him a blowdown and he wore it for 3 weeks. And at 3 weeks, we took it out and everything was fine. Everything had healed over. So I think that, just protect the socket. Don't jump into thinking I need to advance a flap or something like that. I think leave that to your oral surgery friend down the road. And then just give the patient the right instructions.
I think that's very fair.
I think the thing with closing an OAC, when it does need closing, most half-decent dentists, I think, will be able to advance the flap, especially if they place implants and things. So incise the periosteum, do a buccal advancement flap. But actually, there are times when that's the wrong thing to do. So, the anatomy might be difficult, like they might have a prominent buttress. The sulcus might be shallow, might be thin biotype, it might be a big defect. But all of those things, then you're starting to think, right, buccal fat pad or palatal finger or, something else. And I think, I still don't see them often enough to make this a really slick process where I kind of sit and think, oh, right, let me just do this. So I think for a general dental practitioner, it's like, no, you don't need to make that kind of decision. Your job is just protect the socket, so get that splint in, speak to your colleague, and then your colleague can sort out everything else. And I mean, even going back a step, I think just preempt it. Everything we said last podcast about sectioning the tooth looks after the socket loads more, you're much more less likely to cause an OAC, or certainly a big OAC. And then even when it does happen, either leave the socket and support it, or collagen cubes and suture it. And if it's a big OAC that needs closing, fine, take your alginate, put your splint in, refer it on. And I think then you've got, touch wood, all bases covered.
I think that's such great real-world GDP-friendly advice, because you're right, man. Even you don't see these regularly enough as an oral surgeon to make this like an autopilot kind of thing for you. So yeah, why should GDPs be expected, even with implant training, to be able to know exactly which is the best route in that scenario? Definitely sent to an oral surgeon makes good sense to me, but it's a real gem there to take that alginate impression, get that Essex retainer made, and then as part of the pharmacological care, obviously the instruction you give to a patient is not to blow your nose. And now I remember taking out an upper molar at Guy's Hostel as a DCT, and unfortunately I didn't get to see the patient when he came back, but I think he sneezed and he held his sneeze in, and apparently like it was an absolute sight. The antral lining had herniated into the mouth, and that, I mean, how does it even heal from that? I mean, obviously the body is remarkable, but that's not a pretty sight.
No. I've still never seen a proper antral polyp like that. But I've seen some big holes, and I've seen some long-standing fistulas, and particularly the fistulas. If it's been open for a long time and they've had food and drink going into the sinus, it's horrible. It's really full of anaerobes, really smelly. And like I've listened to an ENT surgeon not so long ago, and his advice I can completely get on board with, which is if they get to that point, they need to go and see ENT to properly have the sinus cleaned out and have some drainage before they have the OAF closed. So from our point of view, you want to avoid all of that just by taking care of the communication and not letting it become a fistula. And my instructions would be just like yours. So dab in the nose instead of blowing it. If they're sneezing, they've got to let it out rather than squeezing the nostrils. I'm a little bit funny, like there are obvious pressure differences, like not to go diving for a few weeks, but also plane travel I'm a bit dubious about. So if somebody's got a maxillary tooth that's close to the sinus, I like to know that they're not flying in the next kind of week or two, just in case.
That's a good point.
Then I don't massively go into chemicals. Normal analgesic regime, I wouldn't bother with any antibiotics. You might give them something like Beckinase. And like I think, I don't know what yours was like, but when we were undergraduates, we often got told to give them ephedrine.
Yes.
So ephedrine nasal drops. Now, Jerry, the ENT surgeon that I was talking about, we chatted a lot about this because he's very anti-ephedrine. And his logic is that you stifle the blood supply to the nasal epithelium. And in trying to treat one thing, you actually create another, that you get a rebound disease in the nasal epithelium. So he said for us, ephedrine is either short term, it's just 2 or 3 days, or avoid it and go steroids. So just go Beckinase over the counter stuff.
And that's something that you prescribe, or can you get Beckinase over the counter? Is it like
any chemist? Yeah, or supermarket.
How about Sterimar or those saline rinses just to keep your nasal passage patent?
I probably wouldn't bother. I mean, my question would be, what are you trying to do it for? And really, that's why I wouldn't jump on antibiotics. because really nothing there is infected.
Even if you're giving them a suck down, right? Even if it's like a big enough that you're going to go to the suck down and send to the oral surgeon.
Yeah. I think I still wouldn't. We might be dubious about infection, but those antibiotics that we gave them straight off, they're probably not going to stop that. It's going to be the physically treating it and closing everything that will prevent the infection. And also, if you get to the point where you're teetering into OAF and they have got some kind of sinusitis, the way that ENT treat that with antibiotics will be very different to our way of treating it. Jerry's regime, he said, it's not unusual for him to give people 4 or 5 weeks worth of antibiotics, because he says the absorption's so poor that actually they need a sustained dose over a long time. Now, none of us would ever do something like that.
So that 5 days of amoxicillin that we usually give is really not hitting the spot then.
And I mean, I wouldn't give amoxicillin either. It'd be something like doxycycline, something like that.
Well, there we are. Again, you've surprised me again, and I'm pleased to hear it. I think that's one less reason to reach for the prescription pad. Amazing.
I think this is a kind of prevention is better than cure one. It's like, look after the small communication. Bigger one, shut down splint, refer it on, close it early if it needs closing, and then try and stop those patients getting OAS and sinusitis.
Perfect. Very happy with that. So that's how you manage OACs. Amazing. Well, there we have it, guys. Thanks for listening all the way to the end. Listen, if you're listening on Apple, please give this show a 5-star rating and leave a comment. I love reading them. That's how this podcast grows. If you're watching on YouTube, hit that like button, give us a comment, and I'd really appreciate that. We'll see you in the next group function where we cover the dreaded tuberosity fracture. Like, this is the scary one, right? Like, this is the kind of thing that you see on social media, and the dentist has removed a molar, but actually has removed like the maxilla with it. So this is like the scary one. So let's wait for that juicy one. I hope you never experience a tuberosity fracture, but if you do, you'll be well equipped from this next episode coming. So I'll catch you in that one.